This way you can do that. All right, so we're going to start our second half. We're going to start out with Dr. Pootrakul. Dr. Llana Pootrakul is a native Phoenix, Arizona, whose journey from Southwest to the Midwest includes a college at the University of California, San Diego, graduate school at University of Southern California, and medical school at the State University of New York at Buffalo. Wow, you go from one coast to the other. This path eventually led her to the Ohio State University of Dermatology, residency and Mohs micrographic surgery and dermatological oncology fellowship training. She joined the Ohio State University Department of Dermatology faculty in 2017 and currently serve as an associate professor of Mohs surgery. Her interests and diverse skill set in cancer care and surgery are exemplified when she takes a comprehensive approach to cancer management. She's currently served as the Director of Diversity, Equity, and Inclusion Department of Dermatology and leads our hospital-based Mohs surgery program. Today, she will provide us an update on the dermatology world.
Hi, good morning. I'm Llana Pootrakul, and I'm an associate professor in dermatology. I practice Mohs surgery at the James and Ohio State University. Thank you for having me here this morning. I'm going to be talking about Mohs micrographic surgery for melanoma in situ. And so just for those of you who have never heard of Mohs or had Mohs, we're going to go over the basics of Mohs surgery. We are then going to talk about what the appropriate use criteria are, especially for the management of melanoma in situ. We're going to discuss the different types of procedures that we offer for melanoma in situ in regards to Mohs surgery. And that is slow Mohs or Mohs surgery with MART1 immunostaining. And then we'll summarize the take-home points. Please let me know if you can't hear me, if I'm going too fast, just raise your hand. And so Mohs surgery, I'm assuming some of you have heard of this or have had it or have had friends or family members who have had this, and you've been the person sitting in the room watching. So let's go over the key features of Mohs surgery. The main thing, get it all out. The number one goal of Mohs surgery is to completely remove that skin cancer, and it all happens in real time. So the number one feature we have is 100% evaluation, microscopic evaluation of the entire tissue margin. This 100% evaluation offers the highest evidence-based cure rates for skin cancers. We do this with precise mapping and excision of the cancer tissue. And this allows us to preserve as much of your normal skin as we can. During Mohs surgery, the Mohs surgeon has complete control of your tissue, and this actually offers you true continuity of care when you see us. Immediate re-excision and reconstruction happens on the day of surgery, so it's a one-stop shop. It's very convenient for patients. So let's compare Mohs surgery to conventional or wide excision. And wide excision is something a lot of surgeons do, including dermatologists. This is a schematic of a wide excision. So what happens is, if you can see that little skin cancer in the middle there, we take a healthy border of skin, so a healthy margin of skin. That margin depends on what the skin cancer is and how deep it is. We'll take that healthy margin in a football-shaped excision, and we send that piece off to the main hospital. The main hospital will cut it in a bread loaf, as you can see. Is this showing up here? Yep. As you can see in that last schematic, they cut it in a bread loaf, and we call that bread loafing. It's pretty common sense. And what we examine is actually those slices between the bread loaf. So as you can see, that entire bread loaf itself is not examined. And that amounts to less than 1% of the margin being examined. Well, why do we use this? we do take that healthy border of skin around it. So we just assume that we get most of it out, and we still have the pathologist take a look at it. And so this is actually a fantastic procedure for many, many, many skin cancers. In contrast, for Mohs surgery, what we do is we take a smaller border around that skin cancer and we process the tissue in a way that we squish it down. We flatten it, and then we cut from the bottom and the sides so that we get everything in one cut. And if we see in this third, if we see a little bit of the roots of the skin cancer growing, we come back and we take more only where that root is growing. So we chase it out right where it's growing. We don't take that larger border of skin. We just chase it where it's growing. Okay. And this is sort of a different way of viewing the comparison between a wide or standard excision versus Mohs excision. Ignoring the numbers, if you kind of see these little dark brown bolts here, that represents the roots of skin cancer that you can't see with your eyes. If you look at someone's skin, you can't actually see these. Now, with a standard excision, what we do is we take a bigger, healthy border of tissue so that we make sure we get all of it out. But we're sort of blinded to where those skin cancer roots are growing. In Mohs surgery, we take a smaller first piece, and then we come back and we take more and more and more, only where the skin cancer roots are. So again, ignoring the numbers, you can see just by the size of the picture here, when you compare a standard excision and then your final defect with Mohs excision, we can keep the final defect a lot smaller, but still make sure we get out all the skin cancer. So what happens when you come in to see me for Mohs surgery? If anybody's had a skin exam, and I'm sure a lot of you have, you've seen this tool before. I use a dermatoscope, so I really make sure that I can examine the most precise margin on that skin cancer. I really want to make sure I get just around it. Once I cut it out, and please let me know if this is too graphic for you, we'll quickly move on. We'll cut it out, and as you can see, what's left here is my defect, and I've created some hash marks here at 12, 3, 6, and 9, and that's how I make my map. Why? Because the piece of skin that I took out also has the same exact map on it. We've got our 12, 3, 6, and 9. And then I paint that tissue. So I use purple, orange, and green every single time. I'm pretty predictable. My staff in the lab know exactly what they're gonna get when I bring the tissue back. And he's super happy to see the tissue. This is my Mohs histotech. And then he's gonna start processing it. And what he does is he gets that tissue to where it lays flat so that when we cut it from the bottom, all the side edges that were up here, if you can see the hair follicles, those side edges come down and they're in the same plane as the deep fat. And so we cut that tissue from the bottom and we get everything in one cut. And there's a picture here of my colleague, Dr. Katie Shawan. She generated these photos and these schematics here. And she's actually just starting to do Mohs surgery with us up in our Dublin office. And this is what we see. Once the histotechs are done processing it, this is the slide I get. You can see I have a complete 360 margin evaluation. So I've got all of your epidermis and all of the fat below. If I don't get all this, we can't really say that we did you justice, and we have to go back and cut more and make sure that we examine everything. Okay. Sometimes that piece of tissue is too big to fit on one slide. So I have to cut it in half or quadrisect it. Once I bisect it, I do special paints to make sure that my lab techs know exactly which edge I want them to focus on so that I can make sure I get all the skin cancer out. And so sometimes it's not just one piece or two pieces. For this case in particular, I think we had 13 pieces. So if you can imagine, if I have 13 pieces off the patient and I have to make sure I know exactly where it was on the patient's skin, orientation is a must. And so that's what's really important about keeping everything in-house, and that the Mohs surgeon is doing everything step by step so that that continuity of care is there and nothing wrong happens to your tissue. Same thing, all these little pieces, we're going to flatten them out. This is what it looks like when we start to read our slides. Some of you might know Dr. Abe Corman. He is one of our leads for complex dermatology and hospital dermatology. And the slide you see back there, that's actually basal cell carcinoma. So I'm going to show you a comparison of what, when we do Mohs on our most common skin cancers, which are basal cell and squamous cell carcinoma. And then we're going to talk about why Mohs surgery with MART1 or slow Mohs is so important for melanoma in situ. So this is basal cell carcinoma. Do you have a question?
Just a quick question.
Yeah.
Just curiosity. So you got the purple, the orange, and the green. What do they mean?
Oh, it just helps me know where things are on my map.
Green needs cut more.
No, it just, here, let me just quickly go back. So here, the Mohs surgeon painted blue, yellow, and red, and it just helps identify. Some people don't do double hashes. It just really makes sure that your tissue doesn't get twisted around and that we lose our orientation. Yeah, it's like a safety net. Okay, back to basal cell carcinoma. So even if you've never done pathology before and you're not a physician, you can see this junk of dark purple cells here. This is a very, very positive layer for basal cell carcinoma. Dark purple islands, white spaces we call retraction artifact. I'll show you again. Basal cell carcinoma superficial. A white space here we call retraction artifact, dark purple. This is very characteristic of basal cell carcinoma. As you can see, it's pretty easy for us to see this under the microscope on frozen sections. In Mohs surgery, we do frozen tissue. This is squamous cell carcinoma, not as easy to see. There are pink islands, but we can still see them pretty clearly. Pink islands here, unfortunately, pink island in the blood vessel. And then this is melanoma in situ under frozen Mohs sections. Nothing jumps out at me. And I know you guys don't know what you're looking at yet, so I'm going to explain it. So I always tell my patients when we're talking about melanoma in situ, think of your layers of the skin as the layers of a cake. The melanoma in situ is in the frosting of the cake. So here's our layers of skin. This top layer is the epidermis, and the epidermis includes the stratum corneum, and then the layers below, we can ignore the stratum corneum. And then down here, the lighter pink is the dermis. Melanoma in situ hangs out right here in the epidermis, okay? If it's gone beyond the epidermis, it is no longer melanoma in situ. It is invasive melanoma. So right now, we're talking about frosting of the cake skin cancer. I generally tell people we're in a good place. It was caught early. This is very, very treatable. Okay, back to our frozen sections. Can you see it there? I can't. If you can see something here, you're a better pathologist than me. I'm going to come back to that in a little bit. Let's talk about when we use Mohs surgery, because we get a lot of phone calls of people wanting Mohs surgery. Once they've heard of it, we get a lot of phone calls about why can't I have Mohs or can I have Mohs? About 12 years ago, the big heads of dermatology and derm surgery got together and they put together a paper and some guidelines on what we should do Mohs surgery on and what we shouldn't. And really, this is just to make sure that the people that really need Mohs surgery can get in for Mohs surgery. Because if you think about it, if we're doing Mohs for everybody, the people that really need it won't be able to get in. So we need those people that really need it to be able to get surgery when they want it. So they came up with 270 distinct scenarios in which Mohs can be considered. And how we decide if we should do Mohs is if you fall into a category of 7 to 9, which is appropriate, 7 to 9 points. If you're a 4 to 6, usually we still won't do Mohs. It depends on the case by case. And then 1 to 3, we won't do Mohs surgery. And a lot of this is your insurance company is going to tell you we're not going to pay for Mohs. And so we want to save you that trouble and make sure that we screen everybody from the get-go. What about for melanoma in situ? For Mohs surgery, you qualify for melanoma in situ if you have it on moderate or high risk sites on the body. Size does not matter. You could have a 5 centimeter melanoma in situ on your belly and it won't qualify for Mohs. It's only if it's on head and neck, genitalia, hands, feet, your shins, areas where it's sort of harder to cut out skin cancers and harder to reconstruct. The only exception is if you've had a skin cancer that came back. So if you had that melanoma in situ on your belly, someone cut it out and it's growing back, that qualifies for Mohs surgery. If you've had an excision for an invasive melanoma and you've got a little bit of melanoma in situ on the edges and it's still there, that can get you into Mohs surgery. The two major techniques that we use in Mohs surgery for melanoma in situ are slow Mohs and Mohs surgery with MART1, and I'll discuss them here. For slow Mohs, any non-physicians here probably have not heard the term complete circumferential peripheral and deep margin assessment, especially if you're not studying the NCCN guidelines. But if you hear that term, that's just a fancy term for slow Mohs. And so obviously when I'm talking to people in general, I use the term slow Mohs. These samples, when you come see me and I take that first piece of skin, we send it off stat to the hospital and they process it a different way. We call that permanent sections, and it takes 24 hours. And that's actually the gold standard. Your slides look beautiful. That's why they don't need MART1 staining. The slides look beautiful. The slides are evaluated by a dermatopathologist at the hospital. And I usually bring patients back every 2 or 3 days. That's why it's called slow Mohs. This can actually last for a few weeks. It's kind of like regular Mohs, but we extend it because it takes the hospital that long to process the tissue. And so we're still getting that 100% margin evaluation, and that's why we still refer to slow Mohs as Mohs surgery. If you remember the key features of Mohs surgery, we're still getting most of this. We aren't getting that the Mohs surgeon has total control because we do have to send your sample off to the hospital, and you don't get that immediate re-excision. It happens every few days. Let me just make sure. Does anyone have any questions about slow Mohs? So the reason someone might select slow Mohs, if you're wondering, gosh, why would anybody do that and drive back and forth, is because I might be able to get you in sooner for slow Mohs because the surgery itself is a lot shorter. It takes me 5-10 minutes and then you go home. I might be able to fit you in a little bit earlier. So if you live 5 minutes away from my office and you want to get seen as quickly as possible, that might be the way to go for you. It's essentially the same treatment, but extended. So the key features of Mohs surgery with MART1 immunostaining, and I'll explain that a little bit more. Same as regular Mohs. It's an outpatient procedure. We get you numbed up with local anesthetic so you're not goofy. We go stage by stage. We get all the skin cancer out. Everything happens in real time. For basal cell and squamous cell carcinoma, we get our results back in about 45 to 60 minutes. With MART1 immunostaining, it does take about 2 to 3 hours. So I tell people, you're with me for the day. You're just going to hang out with us, but you will have definitive surgical treatment and you will have reconstruction all on the same day. Still a one-stop shop. And so this is a very popular treatment among my patients. What does MART1 mean? So essentially, MART1 stands for melanoma antigen recognized by T cells. It's a signal on melanocytes or melanoma cells that we can target so that we can look for melanoma cells. We can stain melanocytes. Just remember, melanocytes are both in melanoma and in normal mole cells. So it's going to stain anything made of melanocytes. And again, that's going to be either benign moles or melanoma cells. And so we talked about it being a signal. Let's say this blue circle here is a melanocyte, a mole cell, or a melanoma cell. These little yellow triangles signify that MART1 target. And we use antibodies. I know everyone's heard of antibodies after the pandemic. We use antibodies to detect those signals on the melanoma cells. And those antibodies have a little link to them that can turn a clear fluid brown. And so whenever there's a melanoma cell and we use this MART1 staining, I see brown. And that'll be easier for you to visualize in the next couple slides here. So let's go back to melanoma in situ. Again, frosting of the cake, it's right here in the epidermis. If it's gone down into the dermis, it's no longer melanoma in situ. These are our frozen sections from Mohs surgery. I can't see a darn thing. Here's up close. I still can't see much. And this is what happens when we do MART1 staining. Okay, so that brown is really apparent. These melanoma cells are hugging each other, grouping together, sitting on top of each other. That's not how we want melanocytes to act, okay? They're not giving each other any personal space. This is the same patient with his normal skin, the patient's normal skin. This is what we want melanocytes to behave like. As you can see, all these melanocytes that are staining brown, giving each other lots of personal space. This is what we want to see. I do this on a separate piece of skin from the patient so that's my goal. That's what I want the tissue to look like at the end of the day for that patient. And this is what it looks like when the margins are clear. This is what it looks like when we're to the point that we're done with surgery. So I'm just going to remind you, this is what the patient's tumor looks like. And this is what it looks like when they are clear of melanoma in situ. Okay, just a few cases here. I've blocked out most of the patient to protect their identity. This patient came to me with primary melanoma in situ on the tip of the nose. It was fairly big to begin with for the tip of the nose. So 2 to 3 centimeters on your belly, not that big. 2 centimeters on your nose is huge, especially it feels huge to the patient. Sorry. Sorry. I ran these by food. She said it was okay. We did 2 stages of Mohs surgery with MART1 staining. The patient cleared after 2 stages. We did something called a paramedian forehead flap repair in the office, again, to protect the patient's identity. I've only shown you the nose part. But Kristen, my scheduler, was fine with being the model. The paramedian forehead flap repair, we take a strip of skin from the forehead, we release it and connect it down to the tip of your nose. When we talk about facial reconstruction, your forehead skin is actually a great match in color, thickness, texture for the tip of your nose. So we use that to our advantage. So you have a trunk of skin that's connected from your forehead to your nose for 3 weeks. And patients hate this, but it gives them the best cosmetic outcome. And this is that same patient 6 weeks out. You can see great color match, great texture match. He was very happy. So again, this is his tumor. This is after Mohs. And then this is about 5 months out at the end here, doing very well. This is another patient with MART1. Now, this is a patient that had invasive melanoma. The surgeon did the resection. The pathology showed that there was residual melanoma in situ on the edges. So the patient was sent to me, and I'm going to do a trigger warning. There's going to be a Mohs defect next. So if you don't like gory photos, close your eyes right now. We're going to take our margins here. And then we finished off with 2 stages of Mohs surgery with MART1. The patient is clear. Another kind of gory photo here. We closed this patient up right away with a rotation flap to make sure we didn't pull too much on the mid face. Last patient here. Again, this patient was treated for invasive melanoma, so a more aggressive melanoma. After the surgeon was done, it still showed residual melanoma in situ. So the head and neck surgeon sent this patient to me. We did 2 stages of Mohs surgery with MART1, and the patient cleared. The patient was repaired with an advancement flap, and we left some of the area to heal by something called secondary intention. That's because we were working on the nose and the middle cheek. We wanted to make sure those cosmetic subunits still were separate when the patient healed. And this is the patient 2 months out. Okay, so doing very well. So where are we with Mohs surgery with MART1 at the James right now? Thank you, Patty. So for the referrals that we get or the patients that we see, Most of them, the overwhelming majority, are primary tumors, and that's a good thing. A few, about 20%, are residual or recurrent, like those patients we talked about where they have some on the edges. Or I have patients that say, I had this treated 5 years ago, it's come back, we got to treat more. People who refer to me, most people who refer to me are actually outside of OSU. We get a lot of community dermatologists, community surgeons, people outside of Ohio referring to us for this because a lot of places don't offer it. Internal referrals, about half of those patients are from my department and half of them are from outside of dermatology. And then about 14% are from other Mohs surgeons in the community that don't offer this. And I would say most of them don't. You need a lot of lab support, and it's not something that's easy for a private practice Mohs surgeon to get going. And so it's just, they send them to us and we are happy to see their patients. Take home points. The primary goal of Mohs surgery is, again, that 100% margin evaluation. We want to get it all out. That's the number one goal. Mohs surgery demonstrates the highest cure rate for non-melanoma skin cancers and is shown to be effective with lower recurrence rates for melanoma in situ. It's that precise mapping of Mohs surgery that allows us to save as much of your normal skin as we can. MART1 immunostaining optimizes the identification of melanoma in situ when we use frozen sections during Mohs surgery. And Mohs surgery with MART1 offers patients that option of same-day treatment for melanoma in situ in tumors of moderate and high-risk sites. Thank you.